Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussion surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today we have selected two intriguing cases to discuss.
I have a case for us to discuss today. So this is to give you a brief background, Medicare Advantage plan. So after January 1st, so is a 2 midnight pair. And this is a 76-year-old patient with a history of coronary artery disease and has had CABG. 40 years ago, has heart failure with reduced ejection fraction by 35%, and has CRT placed in 2008 and then generator replacement in 2014. Has also a history of ventricular tachycardia, status post-ablation, and a couple months before presentation, who failed multiple oral medications for this and also has paroxysmal atrial fibrillation, previous thalamic stroke with left-sided hemiparesis, chronic kidney disease, hypertension, the multiple comorbidities, was coming in on 12th of April as a direct admission for VT ablation. He was previously on, so as I briefly mentioned, he's had multiple oral drugs that he failed. So to give more background on that, previously he had tried sotalol, but it was ineffective and thus it was discontinued a couple months before presentation. Has also been tried on amiodarone, but discontinued due to lung function test. Mexiletine discontinued due to nausea, and has been shocked about 5 to 6 times by his ICD in his lifetime, including during his last ablation, when his ICD appropriately shocked him while admitted inpatient for the prior VT ablation. So the patient comes in, is put on telemetry and put on tele, and then underwent an echocardiogram before the procedure to look for clots, right? And there was a concern for echogenicity. So plan was made, okay, let's try to get TEE. And because of scheduling concern and delay, the team decided to go for CT cardiac to rule out the LV and left atrial thrombus. And the CT cardiac, did not show thrombus, did not show clot. So patient underwent on 14. So came on 12th for admission, 13th underwent echo, and then on 14, EP study with VT ablation and LV pacing and recording. It was not complicated. It was uncomplicated, pretty smooth procedure, but then got admitted to CCU post-procedure on 14th afternoon for closer monitoring in the ICU setting. Vital signs all stable. Exam was notable for continued oozing of physicline at the access site. The small hematoma was soft with the but the bleeding improved with pressure on the groin side, then no further bleeding. Patient was put on heparin drip as a bridge, did get a couple doses of IV Bumex, and intermittently did get hypotensive, 80s over 50s, but that improved pretty quickly and was planned to be transferred back to the floor in less than 24 hours on 15th. I'll pause here, pick your brain from what do you think? So this is a patient who's coming in for a planned VT ablation, pretty much as expected course, other than that echo initially showing some echogenicity that required a CT, then VT ablation procedure, but did require post-VT CCU monitoring. So what do you think so far? And it's a 2 midnight pair for Medicare Advantage plan. So you know there will be some resistance from the commercial pair.
You know, I find with some of these, MA plans, it's all, establishing the fact that they went past 2 midnights. That's the start. But it's also making sure you can establish that, especially some of that front end care that leads up to something that's planned, like, was that really medically necessary? Were there any delays in that care? Could you have done it sooner? Because it can get really tricky if they feel like, yeah, well, you should have been able to do that from the very beginning, and if should have been no delay in it. In this one, I think it's a little, the front end stuff, it seems like it's medically necessary. So I think we could justify that. It's valid, a clot. You can't go out with the procedure until you rule this out. Post-procedure, I mean, you add some hemodynamic instability. So I wouldn't, I don't know if that's normal. So I definitely would, I would want, if I'm going to appeal this with a pair, I would want all the details around that. Like they dropped the pressure, we bolus them. We did X, Y, Z, whatever we did to treat that. And even the, why we put them in the ICU. Was there something during the procedure that made them a little bit more concerned? And the hematoma and the drip. I think, I don't know, there's a number of things we could play with here. I think that justify our, medical necessity. Teresa, I don't know, do you have other thoughts being a critical care doc on how you're seeing this case?
Yeah, no, I absolutely agree with what you've summarized thus far, Rebecca, in that, when I see a patient has to go to the ICU, my first question is why? Because ICU beds are always such a shortage, especially at our medical center. I ask myself, what happened? Because docs here know they can't just use up an ICU bed unless there is something of concern. But I'm not sure, Sweta, if that concern was spelled out enough. I mean, I know that you said you saw the hypotension in the flow sheet and in the notes, but I too, like Rebecca, would want to know what was the response to that hypotension, and was the patient symptomatic with that hypotension too? Because that's also going to drive how you look at the case and the complexity post-procedure. In lead up to the procedure, I absolutely agree with the fact that you have to clarify if there's a clot or not, because the patient's already had one stroke. You don't want to have another one because you didn't do the proper checking to be sure that you didn't have a clot you were going to dislodge during a procedure. I'm not sure what the timing was there, but getting the CT was the wise thing to do. But I think the payer could also make the argument that CT could have been done as an outpatient. Did they really need to be in the hospital for those 2 days leading up to the procedure itself? Maybe one of those days, but I would say that if you combine that first day with a needed CT to establish no clot, to prevent stroke. Then you have the procedure day, but the post-procedural ICU stay with hypotension, cardiac monitoring, heparin drip, and a high intensity of services buys you the 2 days of the Medicare Advantage need to complete the final act of the 2 midnights medically necessary.
And I totally agree with you, and that's what we argued on. So initially, and our physician advisor reviewed, they were worked about the same concerns, right? What if this echo could have been done as an outpatient? They would have identified and done the CT as an outpatient and coming straight for ablation, getting admitted in the morning of ablation. But at the same time, even if we get an echo as an outpatient, not always we can get it that timely to make sure right before the procedure there is no new clot that formed in the interim, right? Especially one of the reasons, like you said, we want to do this echo is to rule out clot that could cause stroke. So put in compliance to blood thinner is one of the key challenges like in day-to-day work, right? And that's where I would argue and say, and that's what we ended up arguing for. Like one, that echo was required, and they did CT pretty timely. It was done the same day as an echo, so we could get the procedure done the next following day. So I think, like you said, with the positive finding on the echo, requiring follow-up testing, so we cannot take the patient for the procedure right after echo, buys us that first midnight of medical necessity. And then after the CT confirmed that there is no clot, going in for a procedure. Post-procedure, some of these, like we have a more like a standard process, thrombolysis or procedures which do require post-procedural ICU monitoring just because of the risk involved and not always related to the complication. But I would argue in this case, it was not like a smooth ICU, just 12-hour monitoring that, nothing happened. This patient we had a hematoma, had required more closer monitoring of the hemoglobin. They did not give bolus for the hypotension and think that was more related to the diuresis, so just held for the diuresis. And but definitely that means you have a delicate fluid balance there, right? So anything can hurt the patient. So strict ins and outs monitoring, titrating their diuretics, fine, and then in a setting in the person who needs blood thinner with the heparin drip while they have a risk of hematoma, and that's why monitoring for bleed and anticoagulation planning, I think, is enough to justify for the second midnight and the intensity of care. So we did end up arguing this as an inpatient and getting it approved as an inpatient.
Yeah, restored my faith in humanity there, Sweta. I was hoping that a patient who required all of that and an ICU stay in our facility where ICU beds are hard to get, that we ended up being able to get the denial reversed. That's good.
Okay. Well, I think.
Good. Yeah. Can I ask one more question there and follow up to this case that is not specifically to this case, but to ask both of you? I see we have these patients who come in who are on novel oral anticoagulants and they need a procedure of sorts. And then their anticoagulation is held and they are placed on heparin bridging for sometimes up to 2 days before the procedure can actually occur. How do you guys count those days? Do you count them as necessary? Or what you're thinking about that, or what have you found the payers thinking to be?
Yeah, I personally use that in the arguments of, like, especially when I'm trying to establish, like, we've had patients coming in with something and we needed to work it up, and they needed that next procedure, and there's a midnight or two lost waiting for something to clear out of their system, say, hey, we had to, they agree this needed to be done. And they're like, well, why was it a couple days between, when they came in and when we had to do the procedure? And I said, well, they had this, oral anticoagulant still on board. It wasn't safe to do it. So that is why, or, the valve patients, even prior to the 2 midnight rule, heparin drips for valve patients really are standard of care. And so if you can justify using that, if it's a patient that could have gone with, the heparin drip is one way you could treat them, but you could also use, sub-Q Lovenox, that does become a little bit harder to justify the need in the hospital. I don't know, Sweta, have you had any other experience with the anticoagulant?
I agree with you. And sometimes now, as per the newer guidelines, you don't even need to bridge because technically it's still in your system for 48 to 72 hours. So based on if it's a valvular disease that they need, we want to be safe. So we would put them on heparin drip, or they absolutely need a bridging, so use Lovenox or heparin drip. But come for patients who do not need bridging, but still the procedural would not do the procedure for 48 to 72 hours from the last dose of the of these new oral anticoagulants, right? So I definitely put that into consideration. Like, we do want to do the right next step in these procedures, but we cannot just discharge the patient and say, come back in 2 days and we'll do the procedure. This is not, and this procedure needs to happen in an in-hospital, in this admission, and we have to monitor in the interim and have to wait for the washout. I do use that if applicable during my discussion for peer-to-peer, as the it's definitely a midnight clause, couple midnights, and it looks like nothing much happened in those days. But that still does not mean we could have done the procedure sooner, because that would be increasing the risk, putting them at risk and putting them potential for harm if we try doing the procedure sooner than the time required to wash out that medication.
Thank you both. Sorry, Rebecca, I think you were ready for your case, and I wanted to get your opinion on it. So
yeah, no, that's a great discussion. So no worries.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. APPLCOM is inclusive of all practice settings. Membership in APPLCOM also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, APPLCOM membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acma.org/membership to learn more. Let's continue with our second case.
I am going to shift gears a little bit with a different type of denial that I don't know. I've been dealing with these. In fact, today I dealt with 22 of these. So the theme for my case is it's out of networks. So I think I'm hoping we can, talk about those little subtle nuances of an out of network denial. But so this case, overall ended up being a 3 midnight stay for us. The patient, it's a commercial plan that is out of network for our facility. And this patient's a 43-year-old female. She came to the ED after a fall at her house. She was drinking some alcohol, and she was walking out to her mailbox in her slippers. She dislocated her ankle, but somehow she was able to reduce it herself and get back to the house. Pretty amazed at that. But then it dislocated again. And so then she called EMS and they put her in a splint. They gave her some IV, fentanyl and root. She comes into our ED and the ED physician attempts to reduce and splint, but each time it ended up dislocating. They just could not get it to reduce and stay. So ortho was involved, and they felt like this was an unstable ankle fracture and was going to need some sort of OR intervention, either a closed reduction and or splinting or external fixator. They were pretty certain that the external fixator was going to be needed. So this was, and let me just make sure I've got my dates straight here. So they did go to the OR on the 10th, and they did a closed reduction and splinting with a plaster cast, and they did intraoperative x-rays. So they're like, oh, okay, we did good here. And the patient came out of the OR. Post-op, they did a CT, and there was some, it again had moved out of place. So then was also at that point, they noticed she was having some chest pain, some AFib. And she says she's been having this intermittently for the last month, so these palpitations and chest discomfort. So she got some IV beta blocker, IV cardizem, drip was started. She's placed on Lovenox. Her heart rate got pretty high. It was impressive, up in the 200s. She did have a low potassium and neg, and so they, not surprisingly, with alcohol history, and they ended up treating that. Checked for a PE that was negative, and then part of the situation, we at some point early on were notified that the patient was out of network. And so our case manager, we knew this. They reached out to the payer. It was late in the day, said, hey, this patient is now going to need the OIRF. It's just not stable, and trying to get this approved as out of network. So I'm going to pause there. And I think, I don't know if you have to deal with a lot of out of network payers, and if you do, I guess, what are your thoughts, and how would you typically manage an out-of-network case similar to this at your facility?
We don't have a lot of the out-of-network payers that we have to deal with, Rebecca. It's shocking how many we don't have, because I can see that you are inundated with them, which is an advantage to us. When we think we have it tough, you're giving us the story and you're having it tougher. So I can't say that that we've had that experience with the out-of-network payers. We do have payer plans that are from other states, and we do have to call and argue those particular cases with them. And I think I would just go from the idea that I would be treating it as though it were emergent, because the patient was brought to you by EMS. This is not something that anybody planned on having happen. We can consider this an urgent emergent case. And then everything seems to have been done appropriately, and the case was decided in the OR based on what they saw and thought they could do, with post-procedure films looking good, and then having the complication further that you needed a return to the OR. I think that even makes it a more urgent emergent case that you need to go back and modify for the morbidity that could be obtained because of the failure of the work that was done the first time. If it were me and I had to do it, I would go into it with just the full force that everything done along the way there had multiple steps and complications. And in a patient who's an alcoholic who has alcohol use and issues that may be surrounding that. And you described perfectly the fact that you had atrial fibrillation with RVR that was prominent. And there were other things aside from simply the surgery on the ankle itself, because I know how tight payers have been with ortho procedures in the last 2 years. But this goes beyond just that ortho procedure itself. It also goes to the medical instability the patient was experiencing in and around the time of our operative performances. Sweta, did you?
I think the first question comes is, how would you take care of this patient, or decide on the level of care if it was any other pair? If it's any other pair, I would treat this patient no different, either in network or out of network. If there is medical necessity, there is severity of illness and patient needs, and something emergent procedure, we need to do what is right for the patient, right? Patient first. So in terms of, so what I'm listening, this patient needs all this care, needs all the procedure, needs the surgery, and right thing to do for the patient is do the surgery, then I wouldn't delay it. Having said that, have I run into a situation where we've had, I wouldn't say out of network, but yes, we recently had a case where patient was transferred. We are close to another state, so was transferred from an outside hospital with the trauma, and that too from a pretty good university hospital, but had required a specialized surgeon from our orthopedic department for that. I think if I remember correct, it was something like finger cut. And patient underwent the emergent surgery, everything went smooth, but it's a 2-step procedure and needs second surgery too. And this patient was illegal immigrant, so makes it harder. Did have that state, it's not even our state that we could apply for Medicaid or some insurance coverage. So we ended up going by, let's see what's the right thing to do for the patient. And the right thing was, now, if the pair wants to look for another similar surgeon who's willing to take over the care and wants to take over or have a dedicated transfer plan, we are more than happy to help facilitate that. But at this point, we didn't have a provider that we could transfer the care to bring it back to their in-network provider, right? So patient safety, I would say, is a big concern here, and I would argue for, like, reaching out to those, and even if so I'm guessing when you reached out to the peer, they argued that this is out of network, and so the approval would happen at tricky to get for the second procedure, right?
Yeah, so I think there's a couple of things. Like, we were trying, like, oftentimes we find ourselves in a position, especially we've had this big issue lately with a lot of exchange plans where we think they have a Medicaid plan as primary, and then days into the stay or even after the stay, we're finding out they actually have an exchange plan on top of it, and we're not aware, the patient's not aware. It's gotten very tricky, but so it's oftentimes hard for us to recognize this when the patient comes in the door. So it's really, so I found that, when, the other case that I was on today, it was helpful for me to dig into when did we know about this other insurance to make the case to the payer that, hey, we didn't even know this patient had this plan. It would have been impossible for us to transfer from our ED to another facility, or the patient was too unstable for transfer. That's another angle to take with these cases. This case, we knew pretty early on that this was out of network. We tried to reach the payer that, first day. We couldn't get a hold of them to get out of network approval, because that's another tactic too that I found helpful, is especially when the patients are very sick, is that we try to reach out to them. And oftentimes if we can reach out to them for those sicker patients, they will go ahead and give you that authorization for a big procedure out of network. We do, for example, a lot of, high-end cardiac procedures. And it's also helpful to know if your facility, like you mentioned, Sweta, you have a surgeon or procedure or some treatment that can't be done at the in-network facility. So I try to do my homework on that, especially if I know this patient needs something, that's more complicated. I will ask our surgeon, I'll be like, hey, do you know if the in-network facility down the road can even do this? Do they have anyone, or are you really the only one in the area that can? And that piece of information can really make or break it out of network too. This one, I had an amazing ortho on this one. Wrote a beautiful note on, the 11th when this needed to be done. And it's a paragraph. I've never quite seen a note this good from a surgeon on this, but he specifically said, I think transferring her would have potential for harm to the patient, giving her cardiac history as well as further displacement of the ankle. I think it would be best to proceed with external fixator fixation of the ankle today. And then she can have a definitive surgery at an outside hospital. But he talks about delayed placement of an external fixator increases the risk of early arthritis, postoperative complications, post-traumatic issues due to the displacement and subluxation of the tibiotalar joint. It also puts increased pressure on the chondral surface, which could increase the risk of chondral death. And blah, blah, blah. I mean, it was beautiful. And I was like, that for me on this case was amazing and really was helpful when I argued the case with the payer. So
I'll tell you what, notes like that are very few and far between whenever you look at the surgical procedures. I know they know why, but putting it so eloquently really paints the picture for us and for the payers.
Yeah, and we did get this patient transferred, so I think we made a pretty clear case. Like, we were doing the very best that we could to get this patient to an in-network facility, but we were also doing the right thing for the patient. There was some urgency in what needed to be done for the patient, and we did it, and then we got her to where she needed to be for that next higher level of care for, subsequent procedure. So yeah, that did help us get it overturned. But I do think, for some of these cases, it's, look at some of the other ones I was arguing today, like we even had patients that refused to move. And so, the payer didn't hold that against us. I said, we did our best. We tried to get this patient to go to an in-network facility, but they absolutely refused. So there are different things to try with it, but I do feel like, for us, these have been tricky denials to manage. Overall, we've got a network one. Sometimes, especially if you can't manage it where you can talk to a human being and argue the case and present your side, and you're stuck with a written appeal, it can be really hard to get these overturned.
Absolutely.
Well, thanks for another great case.
Yeah, we prefer peer-to-peer over appeals too. This was a very good case. Thanks for sharing.
After hearing our cases from today, I am challenging myself to bring the next case as one that I have lost, in the sense that I could not get the overturn done, and yet I recommended other further levels of appeal. So next time I'll bring you one that I could not persuade the medical director from the payer to take in any regard. Believe me, I have several if I go back through my records there. So I'll bring that next time for us.
Yes, we definitely don't have a 100% win rate either. So we'll have to, I think there's some of our losses as well. So that sounds great.
Thanks, guys.
Thank you.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Severe, Singh, and Jacobs for sharing these interesting cases in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.